So I welcome you all on the behalf of ISN West Zone Committee. So this is like an important anatomical diagram for radiocephalic AV fistula. So this is like an anatomical snub box. So if you see, this is like a bounded by one is like an extensor pollicis longus and extensor pollicis brevis. These are two tendons. And if you see, the radial artery runs medially and cephalic vein is little bit lateral on the dorsum side. Whenever you do like a radiocephalic AV fistula, you need to be careful while handling the cephalic vein because there is a superficial branch of radial nerve which runs in a very close proximity with this cephalic vein. So cephalic vein is consistently derived from a collateral vein of the deep palmar arch. So in this diagram, if you see the radial artery and there is like a radial nerve, so you need to be careful. Second, I have already discussed there are like two tendons. This is a anatomical snub box and usually it is like a first metacarpal. So here you can easily palpate the radial artery. When you dissect this particular fistula site, you will come across a band-like structure that is a extensor retinaculum, and you need to dissect it to reach up to the radial artery and cephalic vein. So usually like we go for a non-dominant hand in order to create a fistula because patient needs to keep that hand steady during his hemodialysis session. Always look for edema, skin diseases, scars or extensive venous collaterals. These extensive venous collaterals can give you some idea about like a proximal obstruction or occlusion. Distal to the proposed site of AV fistula creation, the extremity should be free from neurovascular compromise. So there should not be any some neurovascular compromise. Otherwise, after like a fistula creation, patient will say like it is all happened because of your surgical procedure. Relevant arterial vasculature should be palpable, soft, easily compressible, and symmetric. And you always take a bilateral blood pressures in both the arms to ensure that there are no obvious asymmetries. So as we are dealing with vessels, you need to be careful about like a people who have diabetic peripheral vascular disease or history of stroke, because in that case you may find atherosclerotic vessels. Past surgical history should focus on assess the procedure, venous system or chest surgery. You look for like patient underwent any major surgeries or permanent pacemakers or so on. So a complete thorough physical examination and history is very important.
Recording in progress.
With this AV fistula surgery. This Allen test and Barbeau test should be performed to establish the presence of collateral flow distal to proposed site of AV fistula creation. Allen test, like everybody is aware, you need to compress both the radial and ulnar artery, ask the patient to clench the fist and ask him to open. The arm gets completely blank because you have blocked both the arteries. You can just remove the ulnar side and you see the perfusion on the ulnar tributaries. And again you can repeat on the radial side. But Barbeau test is more specific and reproducible because instead of seeing, you can put a pulse ox, probe on the index finger and you repeat same as that of Allen's. But instead of like releasing pressure on radial side, you just release the pressure on ulnar side. So you can see that pulse, I can demonstrate this Barbeau test from the OT as well. So it becomes very easy for you to understand. Selection of vessel is very important. Obviously it is like a visual inspection. Palpation of radial artery, you need to visualize the cephalic vein and ulnar artery. Size of vessel is also one of the most important determinant of fistula success. Allen test and Barbeau test has to be done in every patient, and we do ask for a Dopplers of vessel nowadays. So size of vessel is like if the arterial diameter should be around 2 to 2.5 millimeter, cephalic vein minimum of 2 millimeter. The selected segment should be straight and less than 1 centimeter from the skin surface. So there should not be any tortuosity. If there is a tortuosity at the distal cephalic vein, you can go little bit proximal into the forearm. And this is one of the study which published like already been discussed, like how to put a tourniquet over the elbow, and it should not be tight enough to compromise the arterial pulsations. You keep on palpating the radial artery. So what they have noted, if the vessel diameter is on a higher side, so the chances of functioning fistula are high. So that tourniquet test is important. So this is the Allen test. So ask the patient, like you just have to compress both the arteries. Ask the patient to hold a fist, then release it. There will be a complete blanking. Just remove on ulnar side the whole perfusion, like it goes up to like this index finger, like second finger. It will perfuse this much of area, and then you release this hand. Then whole farmer arch is like perfused. It's a both arteries, and distal farmer arch is patent. So this is the Allen test. Ultrasound also gives you information about a vessel diameter, patency, distensibility, depth, a various variation and unsuspected pathology. So even if we do a fistula in MJ-PJY scheme, the ultrasound becomes a mandatory Doppler, both pre and post-op, and that's why it is like almost become a universal in our practice. Anesthesia, the choice of anesthesia obviously depends on the patient's baseline risk and ability to tolerate anesthesia. In pediatric cases, obviously you have to go with the GA or sedation, but in majority of cases, the surgery can be done under local anesthesia. So we do all our these procedures under local anesthesia. So we use a 2% of lignocaine, and in initial days, if you feel the time taken for surgery will be higher, because plain lignocaine acts for 45 minutes, and if you feel your surgery may exceed more than 45 minutes, you can use placed on the OT table. But hand should be rested very comfortably, because it will take minimum of, like for initial days it takes 45 minutes. Nowadays we can finish within like a 20-25 minutes, to do a AV fistula. But it should be comfortable. It should not be abducted to more than 90 degrees. It should be like less than 90 degrees, so that it will not harm the neurovascular bundle. So usually we do take a a vertical incision above the targeted vein. So like as my colleague radiologist told you, we always assess the vessel size, their position and intervessel diameter. This intervessel diameter is also important, because if the vessel's diameter between two legs, cephalic and radial artery, is on like more than like a 3 centimeter, then you cannot do a side-to-side anastomosis. Otherwise, it will add a lot of tension to the anastomos wall and it may get avulsed. And even there are chances of thrombosis, because it will form an acute kink. So vessels, if they are in a close proximity, you can go with the side-to-side AV fistula. If the intervessel diameter is more, you consider a end to side AV fistula. So we always prefer to go with the vertical incisions. Another thing is like how long should be the incision. So I prefer to have minimum of 4 centimeter, 3.5 to 4 centimeter of incision, because it will help you not only during surgery. There is like nothing like a short incision and making a cosmetic surgery. We have to have a good vascular anastomosis. That is our end result. Many of the times you can see the vessel, good vessel, but after anastomosis you will realize there is no thread, and it happens because veins have multiple valves. So if you can visualize that vein at least for 1 centimeter, you can even dilate. Put like a nasogastric tube, or even like we have a venous vein dilators. You can straightway see whether there is any venous valves are there or not. You can even visualize the kinks. Even you can visualize the peripheral tributaries, which you can ligate, because they are not going to be useful for the future cannulation. So incision should be adequate enough to mobilize the vessel, see the vessel, and do a good anastomosis without traction under the chin. because handling of vessel is a very important thing. If you handle like most of the times radiocephalic is a difficult fistula. Means it is not as easy as that of like a brachiocephalic or elbow fistulas, because vessels are here are small. Majority of times in elderly patients they are calcified. They are most of the time they are being pricked for some or other procedures. So you need to be very careful in radiocephalic AV fistula. So where to give that incision? Like if the distance is high, always try and give incision towards the arterial side. If the vessels are in a close proximity, you can go in between. So I prefer, like if the distance is like a 2 mm, I will go exactly between the vein and artery. So after mobilization of vessels, what you will find, like a radial vein and radial artery, you have to mobilize it. Like my colleague Dr. Devdar said, you don't have to mobilize arteries, like from below and everything. But in initial days, you need to have a complete vascular, control on arteries. I prefer you should have at least like, some space to put a bulldog and to put a slings so that nothing goes wrong. Because we are a physicians, we are not a surgeon. So I prefer like over a period of time, yes, like you simply put a bulldogs and do the surgery. But initial days, yes, make a good, like mobilize the vessels completely, put slings, and then only you start doing the arteriotomy or venotomy. So this is like what we have created is a side-to-side AV fistula here. So this is a small. As we started doing this fistula more and more frequently, our incision automatically, is becoming smaller. And this is like these are hardly 3 or 4 sutures. So in some cases, it happens like you don't have a good, radiocephalic artery or venous system, and then you have to consider some other. I always prefer to look for ulnar side as well. This is one of the old patient who she had this like a radiocephalic AV fistula. She underwent a cadaver transplant, but unfortunately after like 7 years she had a can and lost her graft during COVID pandemic. Then obviously like I planned to do like a fistula for her. So instead of going like proximal side, I thought it is better to look for this basilic vein. So if you see the continuation of basilic vein, you can see the small basilic vein here. And we did like a Doppler, and it was like ulnar was patent, Allen test was good, so everything is okay. So we constructed a basilic ulnar fistula on this side. So sometimes you try and utilize these both sides rather than directly jumping towards the elbow fistula. So once you do a good anastomosis, the important part becomes for nephrologist is like a maturation of fistula. Obviously, like there are like almost literature says 30 to 40% of like a primary and secondary AV fistula failure. But to be very honest, if you start doing it, that number is just a number. We never had like a 30-40% of failures. Majority of times, if you select vessels properly, do meticulous anastomosis, there are very few chances your fistula will fail. So, but next is like a maturation. We need to have a very good matured AV fistula. And there are certain characteristics. One is like we should able to have a good flow during dialysis. So everybody, like most of you are aware, like the rule of 6. So just back, one second, back, no, back. You are going to put it on. Back 170 kg. Yes. So flow volume should be around 600 ml or more. Diameter of vein used for cannulation after like maturation should be minimum of 5 mm or more. Mature fistula can provide a sufficient cannulation segment length, and that should not be like a depth should not be more than 1 centimeter. And we always try and see that like matured vein should be cannulated with 2 needles. A major obstacle for successful AV fistula creation is maturation and wait for like that fistula to mature. There is nothing like hurry. Always wait for minimum of 4 to 6 weeks if you want that fistula to work for a longer time. Sometimes this small vessel, particularly in females, it will take a longer time. Wait for another like a month, even for 4 months. So unless and until that waiting time is also important. Sometimes we say that fistula is not working. It is better to wait because with time and with constant pressure and hyperplasia, you are going to have a good fistula. So it is like a process by which fistula becomes suitable for cannulation. It is a rule of 6 mm in diameter, less than 6 mm deep, good flow around 600 ml, and maturation time is 6 weeks. So this is like if you have a good mature AV fistula, the chances of a good dialysis are high. So there are certain devices, they have been published. This is one from a KI. So majority of times what happens, you have very small thin walled cephalic vein and calcified arteries. So what they have used certain devices like this vascu device. It is like a place at end to side anastomosis, and because of its like a strength, tensile strength inside, it will help to maintain the patency at the surgical site. Another device is like being reported is the OptiFlow implant. This is a conduit, but obviously I don't think it's available in India at present. These are like open surgeries, and the day is not far when we will have interventional AV fistula creation. So I think 2 years back, before COVID pandemic, one of faculty from Canada, she visited Aurangabad, and she discussed about like this 2 techniques of developing percutaneous AV fistulas, and the method they use is like a radio frequency ablation. So here what they do, they go retrogradely and they put 2 catheters, one in artery and vein. So, and as they go, it is like under fluoro guidance in cath lab. So once they reach, and if they found a suitable site between a close site between like artery and vein, they actually they activate that instrument, and both that electrodes comes together and they fire, and because of radio frequency ablation, there is a communication is being created between artery and vein, and they remove these electrodes. And this is like what they have demonstrated. So there are 2 systems. One is the ellipsis vascular access system, and another is the Everlink Endo Ultra AV fistula system. These are 2 systems. I think presently this is available in Canada and 2 centers in USA. Another like, can we use some drugs to increase or decrease the rate of thrombosis? So there are certain drugs and drug delivery system are being used. So this is one of the paper published in KI. So they have used like a sirolimus, munapinatase, vasuco gel, and paclitaxel eluting mesh. But I think these are almost into like a phase 2, 3 and phase 3 trials. At present, like my experience with AV fistula creation is like identifying the proper site, good vessel, good anastomosis, and you need to give a continuous flush with 100 ml of saline with 1000 units of preparing. Keep flushing the vessels, ask your assistant to flush when you do anastomosis, and with proper techniques, I think the result of AV fistula creation, successful AV fistula creation will be definitely on a higher side. So because like we are not trained in doing AV fistulas in our residency, so when we came to Aurangabad, I learned from Dr. Pargavkar, Dr. Bhavikar, even our CBTS surgeon, plastic surgeon. They are the pioneer who started doing AV fistula in Marathwada region. So almost like a majority of nephrologists in my town, they are doing fistulas on their own. And not only like we are catering not only to our patients, even like a periphery nephrologist, they are referring patients for AV fistula creation to our center. And like 4 years back, we are one of the centers for vascular access recognized by ISN. We do have like one International Society Nephrology fellow here with us for 6 months. So there is a lot of learning curve, but you can achieve whatever you dream for. Like my colleague Dr. Sachin Soni taught me how to start with the AV fistulas. You know. Good afternoon, everyone. So here I am going to demonstrate you about like the initial stage about like the radiocephalic AV fistula. So this is like a cephalic vein which is marked with a dotted line. You can see a dotted line here. It's like a cephalic vein, and here we can palpate a radial artery. Find a like both it goes like this. So distance between radial artery cephalic vein is not much. So I am going to infiltrate a local anesthesia that is okay subcutaneously and put a vertical incision of veins and artery. So make sure before you put anesthesia, you always try and aspirate and see it should not damage the vein or artery. So after infiltration, you need to wait for like at least 1 to 2 minutes. So by that time you can anesthesia over there. So I am going to put a vertical incision in a radial artery and cephalic vein. So almost like a 4 centimeter for demonstration purposes. You can visualize it properly. We are going to dissect the radial cephalic vein first. Do an incision on some small vessel reader. Try to find out like the use electropottery for hemostasis so that it will not disturb your oxygen. Taking proceed like surgery. Small vessel which is running just because obviously it is a small superficial vein, so we don't want. So I am detecting the subcutaneous vein now. So if you are used to like a cautery, if you have access to cautery, I think it's a very good choice to have a cautery in OT so that you don't have to ligate each and every vessel, and cautery is a very easy way to deal with small bleeders. So after like initial detection, you can able to visualize the cephalic vein before. So once you detect it, I will try and put a sling or umbilical tape here so that I can make sure the vessel should be like inside, and my assistant will scaffold of it. Obviously, you have to make sure you should not put a lot of traction, and every dissection has to be done under vision. Hope my voice and the quality of video reasonably okay with you all guys.
Yes, sir.
Okay, thank you so much. So now this is like a cephalic vein. So I just see this cephalic vein from the surrounding field. So always try and do like you always prefer dissecting away from the vessel, not directly near the wall. And if you find some small tributary, you can catch hold of them, cauterize it, cut it. This is how you need to proceed, because like you don't have much space here. So I need a help from my assistant, and now there is like a small tributary here, so I am doing a vascular clip, like a small branch. So we are doing a small vascular clip here instead of cauterizing this vessel, because after you do a fistula, small vessel can be like cause a lot of bleeding. So under vision, put this vascular clip. Okay, so fair enough. We put 2 clips like this small tributary. Now we are almost done with the cephalic vein, right? So I will proceed with the radial artery now. So always make sure not to detect from the subcutaneous vein, because as I told you, luckily we don't find that superficial branch of radial nerve near to our vein. That is good. One point to be very vigilant also. On reader or right. Now I will go this plane and get rid of like a surrounding tissue with ease. So now in this plane, as last during anatomy of that particular area, I shown retinal. This is like a small paper is just overlying the artery. So always make sure not damage the artery, which is just lying below this. This is the retinal. So now you can palpate the radial artery here. So once you palpate, you can extend your vision and try to reach up to the radial vein, radial artery. But then you can see the pulsation over here. Here you can find that radial artery quite deeper. I need to get the tissue reticular to dissect it first so that I can mobilize the artery properly. So here is like a radial artery. First time, just mobilizing, gently dissecting it so that I can put sling around it, the radial artery here. Usually it is associated with some small metavascular like small vessels. Be gentle with them. So now we can, even like for visualization purpose, we put this worm retractor just here. Now you have like one, the left cephalic vein, and another tape towards the radial artery. I think it is visualized more. You don't need a big stuff here. You just have to dissect the artery from the anterior aspect so that you can put your bulldog. So this is like a small nerve to be careful. So I am going to use the nerve hook here, then small nerve surveillance and separately for patient now on its place. Touch or damage it and never cauterize it. Much of dissection for artery to the sling, they can use over here. So now I just see whether I may be able to do this side to side maybe fistula. If not, I will go to the end side. So if you see, because like there is a lot of traction on the vessel, if I just try and do this side to side, it's not that difficult, but I don't want any type of key. So I will proceed with like a end to side AV fistula. For end to side, flush it, flush the whole thing, take it very clear. So now this is a radial artery, this is a cephalic vein. So for end to side AV fistula, I need to ligate a distal end. So I will put and tie the distal end. So if you see, there are two small, like this is like what initial discussion was all about, like venous hypertension. So if you see, this vein is like having is being filled with like a small two distal tributaries. So I need to clamp, ligate both. So whenever you tie, at least 4 knots for tip and 10 knots for swelling. So this is a standard. Now with the help of like a fine scissor, I am going to cut and ligate this laser. So this cephalic vein is literally ligated and cut. So I will flush this vein using the vascular forces. So these are like a small directed vascular forces. So you need to catch hold of, and you see there are like 2 holes in just the junction of these two. I will flush this vein, and once you start flushing this vein, you will find that it is significantly dilated, and easily you can flush this vein. So I don't find there will be any obstruction proximally. So flush the vein, it will get dilated. Flush with at least 20 to 25 ml of saline with heparin. Once you are done with this flush, always make sure your orientation should be appropriate and put a small bulldog here. So if you see, I put this bulldog like above skin so that it will not damage the vessel wall. So that is one. Now give me the scissor. So I will make a venotomy incision over here. So this much of venotomy is enough. So this is like a venotomy, and like I will proceed with the arteriotomy now. So I will put a bulldog over here on the arterial side, okay, and one proximally and one distally. Now this is like, this helps to make a vein stable. This is called as a ballocking. So you don't have to put a lot of traction on the artery. Just make sure you should not get turned up when you do anastomosy. Therefore, like a fine bit, I will just inject the extra tissue which is overlying the artery, so that I can do my anastomy, and this tissue will not come in between my region. So I will just make a small that lesion, which is called like this. That is done. So now always keep flushing. That is a very important step. Now with the help of 11 number tablet knife, I am going to put the arteriotomy incision. So now you see, this is like a venotomy what we have done, and this is like an arteriotomy. So again, always keep your edge of the blade facing upward, so it will not damage the posterior wall. So these are like a vascular forces, so I can, without damaging the intima, I can do arteriotomy under vision. So this is like we have done with our arteriotomy. Now we flush this artery, like a tape the line, keep flushing it. So now I will start with my anastomosis, and this is called as a parachute technique, like a parachute, because we have to do a end to side anastomosis. So this is how my vein will go, like this. Okay, so I will start with my anastomosis. So obviously I need a help from my assistant, so he will catch hold of outer side of inner wall. So another important step is like always keep white watches on these bulldogs, because this thread may get entangled with this bulldog using your surgical technique. So it will catch hold of like a outside of the venous wall, and these are like very fine vascular tissue. So they have to always, as Dr. Devdar told you, always have to have good instruments, and I will start from like this dental incision at the base of venotomy, and obviously then I will start with the arterial side. Okay. So this venotomy starts from here at the base of incision, and then I have to start from the middle of the artery, exactly middle, so that both sides will approximate properly. And make sure you will try and include each and every wall, like appendicia, media, and intima into your suture. So this technique is called as parachute. So I will go. For demonstration, actually I am just using this forceps into the vessel wall more frequently, otherwise we don't. So initial sutures you have to be very careful, because you cannot turn the vessel once you are done with the anastomosis. Anterior wall, yes, it is easy, you can put another couple of sutures if there is a bleed, but on posterior side, yes, you need to be careful. If you see my sutures, they are hardly like less than 1 millimeter away from each other. When you do a veno-arterial anastomosis, always try and on venous side, the suture should be very close to the vessel wall, very close. Arterial you can take a deep bite, but on dinner side, very superficial, very near to the edge, because we want that intima to intima get closer. We take another 2 minutes for me to complete this side. So make sure like all threads have to be careful, they should not get entangled, then other way on you have to again do the anatomy. It is little bit difficult as compared to put in side to side fistula. So I almost put like a 6 suture, and then with the help of another suture, I will just try and bring these 2 walls closer. This is like I am done with it. Okay, so I am done on this side. I think this technique will definitely help you, and I now short of time actually. So we will do within like 5 minutes. Now you need to be careful about the corner, like the last is from this side of wall. If you have doubt, better put your vascular forceps, no other forceps, only vascular forceps, and do the suture on the region. So here I am done on this side. All sutures should be under the region. No posterior wall because it is from the pointing on the anterior wall. So I will stop here because I am not able to visualize if I continue on this suture. So I will go with like the aim which I left previously.
Hello. Sir, will continue? Barnela sir?
No. If you want to like change to OT number 2, you can. I will just finish with my anatomy.
Okay sir. Thank you. So here comes the end of first session.